A 50 years old right-hand dominant carpenter and a tennis player presented with pain and localized tenderness around the right elbow. The pain is well localized to the right extensor muscle mass, just distal to the elbow joint, and has been there for the last 6 months. The pain is aching and burning in character and radiate distally towards the forearm extensor musculature. He is also noticed slowly enlarging mass over the dorsal proximal forearm and complains of weakness in the grip strength and diminished endurance. He has no sensory loss of the hand or the forearm and denies any trauma. You move forward with physical examination of the patient and you measure 2 centimeter forearm being larger than the left side with respect to circumference. A palpable mass is noted over the dorsal aspect of the forearm, and the patient is tender at palpation over the radial nerve as it passes towards the mobile muscle mass and just distally to the radial head. Tenderness and palpation is noted at the same area of the left forearm but not as severe. Directly palpation on the lateral epicondyle causes some discomfort but less severe than the distal one. Full passive flexion of the wrist and fingers with the elbow in extension produces pain. Resisted supination with the extended arm similarly reproduces the pain symptoms. A radial deviation was observed at wrist extension. The patient is able to fully extend the interphalangeal joint but cannot fully extend the metacarpophalangeal joints beyond 45 degrees. A radiograph is advised and does not show any bone abnormality, but a soft tissue shadow is noted in the radiograph. MRI of the proximal forearm reveals a mass consisting of lipoma involving the supinator muscle. The EMGs and nerve conduction studies for bilateral upper extremities demonstrate denervation of extensor digitorum communis and extensor carpi alnaris. The abductor pollicis longus and extensor pollicis longus and brevis are spared. What is the diagnosis? And what can be the differentials? The diagnosis here is posterior interosseous syndrome, but the differential can be radial tunnel syndrome, cervical radiculopathy, lead poisoning, and systemic connective tissue diseases. A radial tunnel syndrome involves compression of posterior interosseous nerve branch of the radial nerve. Radial tunnel syndrome is defined when there is absence of muscular involvement, and the diagnosis of posterior interosseous syndrome is defined when there is muscular weakness and atrophy of the efferent distribution. Remember the fact that the posterior interosseous nerve is not just purely motor nerve. It carries gamma afferent fibers of the muscles it innervates. This can be demonstrated by the comfort experienced by squeezing any muscle belly. The posterior interosseous nerve also supplies sensory afferent branches to the radiocarpal, intercarpal, and carpometacarpal joints. Patient may describe aching, burning, discomfort, or mobile extensor WAD musculature, which may radiate distally down the forearm. The radial nerve rises over the posterior cord of the brachial plexus and about 4 cm proximal or distal to the radiocapital joint. The radial nerve divides into 2 large terminal branches called radial sensory and the posterior interosseous nerve. Anatomical compression of the posterior interosseous syndrome can include fibrous band from the anterior capsule, origin of extensor carpi radialis brevis, recurrent leash of vessels, and arcade of Frost. The structural compression of the nerve in elbow extension, passive forearm pronation with wrist flexion and wrist supination is noted. Active forearm supination has been reported to produce 5 times more greater pain and pressure than passive forearm pronation. Unlike radial tunnel syndrome, there are many causes of posterior interosseous nerve syndrome other than purely anatomical as described. Trauma involving the radial head or dislocation may result in pin injury. Any space-occupying lesions may compress the nerve in the radial tunnel. Ganglion lipomas and fibromas have been reported to cause compression of the posterior interosseous nerve. MRI may be helpful too if there is a mass suspected. The posterior interosseous nerve may become compressed in patients with rheumatoid arthritis, secondary inflammation or subluxation of the radial head. This can be differentiated by the tenodesis effect of the flexion and extension of the wrist. Pain is frequently the primarily initial complaint, followed by muscle weakness and paralysis, which happens in weeks' time. Occasionally, weakness may occur dramatically overnight following unaccustomed exercises. The sequence of muscle involvement and pin injury is not set. Patient with motor involvement may notice weakness and radial deviation of the wrist. This is because the radial nerve proximal to the radial tunnel innervates the extensor carpi radialis longus and brevis. Patient maintains the ability to extend the interphalangeal joint of the fingers but may unable to be extending metacarpophalangeal joint beyond 45 degrees. Partial paralysis may result in loss of extension of the small and the ring finger alone, producing false appearance of ulnar claw hand. However, the metacarpophalangeal joint should not be hyperextended and the ulnar nerve intrinsic musculature should be intact. Thumb extension may or may not be involved, and there is no sensory loss. When you talk about the differential diagnosis, the first differential diagnosis is the radial tunnel syndrome. Remember the fact that radial tunnel syndrome does not have any motor involvement. Cervical radiculopathy is a second differential. Any patient having elbow problems should have evaluation of cervical spine. A Sperling maneuver is helpful to evaluate for cervical radiculopathy along with thorough neurological assessment. A cervical spine radiograph could be performed if the cervical spine is in question. Cervical spine pathology usually present with sensory symptoms. Another differential is rheumatoid arthritis may present with lesser than loss of metacarpophalangeal joint extension due to the extensor tendon rupture or posterior interosseous nerve palsy. Patient with pin palsy may be differentiated from ruptured tendon by tenodesis effect with wrist flexion extension. The MCP joint extend with wrist flexion if the extensor tendons are intact, suggesting that lack of extension is secondary to the posterior interosseous nerve palsy. EMGs may be helpful as well. Going towards the management of pin injury, a non-surgical management of pin syndrome includes rest, splintage, and activity modification. NSAIDs may be helpful primarily to pain relief. Corticosteroid injections generally have minimal benefit because neuropathy is compression, not synovitis. Job provocation can be changed, will have some benefit. Splintage should provide some muscle if paralysis is present. It's important to emphasize full range of motion of the joints in case of muscle paralysis to prevent contractures. Patient with acute motor weakness without evidence of mass may demonstrate spontaneous recovery. While talking about the surgical intervention of pin compression or posterior interosseous syndrome, it's important that clinical and electrodiagnostic studies should be done. And they are not changing with last 6 to 9 days. Patient with confirmed mass compression of the radial tunnel should be considered primary for surgical management. The symptomatic radial tunnel that progresses to extensor motor paralysis is an indication for operative compression. When talking about surgical decompression, there are 3 techniques. One is brachioradialis splitting approach. Second is anterior approach, and third is a dorsal approach. The brachioradialis splitting approach. A 6 cm curve or straight incision is made over the mobile ward, starting at the level of cubital fossa and extend distally. Dissection is bluntly taken down to the fascia to protect the cutaneous nerves. The brachioradialis is then bluntly split, aiming towards the radial head. Blunt dissection and retraction of the blunt retractors reveal the radial nerve with a fibrofatty layer. Dissection proximally demonstrates the radial nerve as it divides into pin and the sensory branch. The fibrous bands are released over the radial nerve. Bipolar electrocautery is necessary to release the leash of recurrent radial vessels. The pin is then traced as it passes under the proximal edge of extensor carpi radialis brevis. Occasionally, the nerve gives off motor branches to the muscle at this location. and this needs to be protected. The proximal edge of the supinator, which is called arcade of Frost, is then identified. Care must be taken to identify the proximal edge of both the extensor carpi radialis brevis and the supinator. It is easy to release one of the extensor carpi radialis brevis, thinking that this was supinator. The supinator should be released through its entire length in pin syndrome, and meticulous hemostasis is secured before closure. Regarding the posterior approach is useful when the mass is present in the supinator muscle paralysis, as most distal compression of the nerve is easier from this approach. A 6 cm incision is made over the dorsal proximal forearm parallel with the imaginary line extending from the lateral epicondyle to the Lister tubercle. The interval between the extensor carpi radialis brevis and extensor digitorum communis is developed. This interval is easier to develop distally than proximally. The pin is identified and as it exits distally through the supinator and is then traced proximally. Regarding the anterior approach leaves a large unsightly scar. Although identification of the radial nerve is easier proximally through this approach, it becomes more difficult to fully release the posterior interosseous nerve distally. Care must be taken not to injure the lateral antebrachial cutaneous nerve. This approach is really used for radial tunnel decompression. Postoperatively, the patient should have a sugar tongue splint for 1 week, then placed in a wrist support splint, and the range of motion exercises are initiated. Resisted exercises are started at 6 weeks and are progressed.